All right. So, as promised, this week we're going to talk about psychological disorders. And before we get to that, I just kind of want to give you a little bit of a heads up as to what we're going to be covering. Now, with this, I tend to kind of hit home for a lot of people. A lot of students might be able to relate to some of these things that I'm talking about. Okay. And a lot of what we base our theories on are the medical model that we've seen. We've talked about that in the past, right? We try and use the diagnosis to get somebody the proper care that they need. And there's a lot of empirical data out there that shows that ways to treat psychological disorders are sometimes universal, right? No matter who you go to, usually the treatment's going to be the same for like PTSD or anxiety disorder or something like that. In general, okay, they may deviate a little bit, but for the most part, we're not going to use extreme exposure therapy, for example, for somebody who's suffering with PTSD. We could actually make that condition worse. So no matter what therapist you go to, usually they're going to be treating that about, in the ballpark the same way. All right. So with that said, we use psychological disorders. We use a lot of labels. Okay. The one thing that labels are good for, again, treatment. Figuring out what treatment modality is going to be the best. Getting it paid for by insurance companies, right? Because they want to know what's wrong. They don't want to be shelling out $250 an hour for somebody to go sit down and talk about stuff with not having any kind of goal, no plan, no nothing, right? So they insurance companies want to make sure that there is an actual reason for somebody to be there, and we do that through labels, right? Which is exactly what diagnoses are. It's a way for us to label what somebody's going through, usually long term. Could be short term. There are a lot of diagnoses that are meant to be short term, like adjustment disorder or manic state or fugue state or something like that. Usually those are just a single episode and usually it goes away. Sometimes they last a little bit longer, which we'll talk about, right? All right. So let me share my screen with you so you can follow along with what I'm going to be talking about as well. Okay.
I'm sorry. Um,
hmm
I don't mean to interrupt, but it's really hard to hear you. Like your speaker seems like it's really low because my volume's up the whole way,
Okay.
but it's like really low. So
Um, all right. Is everybody else having the same issue?
No.
No.
Okay. I'm coming in clear on everybody else.
Yeah.
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 All right. So, yeah, might be just a mismatch of audio or something here. Anyway, so if you can all hear me clearly, yeah, maybe just listen a little closer. Um, maybe I think there's a way to do closed captioning as well, if that'll help. Will that help if I put on closed caption?
yeah, it's just like everybody else is really loud and then yours is like low.
Okay. Okay. Copy the APA token. Copy this token and paste it in a third-party closed captioning tool. I don't even know what that means. APA token copied to clipboard. All right, is closed captioning coming in on anybody's? I don't even know how this works. Copy and paste closed captioning. Yeah, I'm not too familiar. So I thought I would just be able to hit a button, but it's saying assign a participant to type, or I will type. All right. So yeah, I apologize. I don't know how to use the closed captioning. So yeah, if there's anything that you need me to repeat or clarify, just let me know, and I can go back and cover that. Does that work?
Yeah, thank you.
Okay. All right. So we haven't done this in a while. So let's do fact or falsehood, okay, or fact or myth, or whatever you want to call it. So let's see how you do on these. So psychiatrists label behavior as disordered when it is deviant, distressful, and dysfunctional.
True.
True? What does everybody else think?
True.
True, true. I meant to bring up my participant window as well so I could see what everybody's answer. So the general consensus is true. Okay. Sorry. All right, there we go. So yeah, that is absolutely true, and we're going to talk about what these three terms mean as we go through this. So yeah, more to come on that. All right, next one. In some cultures, depression and schizophrenia are non-existent.
True.
True. It's actually false. The a lot of we see this worldwide. People that go into depression and schizophrenia, we know that are universal. Anxiety may not be necessarily universal in some cultures, but depression and schizophrenia are. Okay. Research suggests that the stigma and stress associated with being gay increase the risk of mental health problems.
True.
Yeah.
True.
True, absolutely, and we'll get into that when we talk about gender identity dysphoria, right? About 30% of psychological disordered people are dangerous. That is, they are more likely than other people to commit a crime.
False.
False.
False, absolutely. Good job. All right, and last one. About 1 in 4 adult Americans suffer from a diagnosable mental disorder in a given year.
True.
Yeah, absolutely. That's true. Surprising numbers. And actually, that number is very, very low. If you think about that, why is that? Why is that number low? 1 in 4.
Because people don't like go to the doctors and be like, I have a diagnosis, I have a mental disorder. Maybe,
Right.
you know.
A lot of times, like things like depression or insomnia or anxiety can be settled within that person, the person themselves. They can get to, we are, for the most part, a well-oiled, well-designed human machine that can solve its own problems and take care of itself, right? For the most part. Sometimes that doesn't happen. And sometimes people need to go to the doctor because of an injury or because they can't sleep or there's some other kind of dysfunction going on in their lives. In those cases, usually the doctor or the psychologist can help them with that, right? But anyway, so psychological disorders, as I mentioned, are deviant. We call these the 3Ds. So if you want to remember these, any of you going into the field, you'll be very familiar with this. Deviant, distressful, dysfunctional patterns of thoughts, feelings, and actions. So what do I mean by deviant? What does deviant mean? Deviant means not normal, right? We look at things as deviant as in a majority of other people are not doing those things, right? So for example, and I think it's a great example now is homosexuality a deviant behavior or thought? Engaging in homosexuality, is that outside of norms by today's standards?
No.
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 It's very very it's very accepted. It's normal in most circles, right? However, if you go back 50 years from today, like back in the 1960s or 70s or
I was just about to say that.
yeah, was it deviant back then?
Yeah, it was not accepted that much.
Right. It was actually classified. Homosexuality was classified as a disorder, a psychological disorder back then. So, we're using the DSM-5, version 5. So we've had 5 iterations of the DSM since the 1950s, and we'll talk a little bit more about what the DSM here is in a little bit. But it's a constantly evolving document, a publication that incorporates, what are some of these norms, what used to be deviant and is now accepted, for example, right? So I always use, okay, I'm sorry. Let me go back to the other 3Ds before I get into the example here. So distressful, is it distressing on that person? Are they experiencing some kind of physiological distress? Are they visibly upset over this? Or are they visibly upsetting other people, right? Visually upsetting. Get into that again. And the other part is dysfunction. So what is dysfunctional? Like, for example, like if somebody comes to me and says, Doc, I haven't slept in 4 months. I'm irritable at work. I sometimes I can't, I fall asleep on the way to work. I fall asleep at the desk. I just can't get enough rest. Okay. That to me is a dysfunction. Why? What is happening with that person's quality of life? Because they can't sleep. What do you think?
They're probably not doing very well and on edge and stressed out and sleep deprived. Yeah, they're not very
Right.
healthy.
Yeah. We all have sleepless nights, and sometimes we can just kind of get through the day, may not be our best version of ourselves, but we wouldn't necessarily call that dysfunctional. But when it's ongoing and it's invasive and that person is not able to function, and we see their quality of life going down because maybe their relationships in jeopardy, maybe their job is in jeopardy, we would call that dysfunctional. Okay. And that has real serious implications that we have to really consider, right? So just to kind of merge all these three together. So we look at that to make sure that all three of these are indeed present for us to consider some kind of diagnosis or some kind of treatment, right? So, for example, if you let's say you go to a church and you see a woman sitting in the pew talking to a relative that passed away. Is that deviant behavior? Is that strange? What do you think?
Not necessarily.
Why not?
Um, well, within the context of the religion, it might not be seen as abnormal within in that culture of that religion of speaking to somebody who may not be here anymore.
Very good. Yeah, absolutely. In the context of that environment, talking to somebody that has passed away might be a form of some kind of prayer or ritual in order to connect with that person in their grieving process, right? So we wouldn't really say that's deviant. Is it distressful? Probably not, right? That might be a coping mechanism for that person, nor is it distressful for people around them because they would kind of expect that to see that in church. Is it dysfunctional? Is it affecting that person's relationship in that environment? Probably not, right? So we could say that that's a pretty normal behavior. Now, you take that same person and you take that same woman and put her on a public bus, for example, and she's doing the exact same thing. We would probably say that that's not normal, right? We would say that's deviant. It might be distressful for people around her, and it could be affecting her ability to communicate with other people, right? So it's all about context, and when you think of that, so and as a psychologist, as somebody that helps other people with talking, I have to be culturally aware of what some of their normal behaviors are in their culture, because I could make a misdiagnosis because somebody is expressing themselves in a way that is normal within the context of their culture, if that makes sense, right? So anyway, so another point about psychological disorders, it can be defined by, oh, I already talked about that, culture and context, so got ahead of myself. And it can change over time. So what is considered a psychological disorder can evolve either for the better or for the worse over time. So somebody that comes to me one day with depression and anxiety, if it's left untreated, or if it's misdiagnosed, or that person doesn't seek help, it could evolve into something more serious, like an eating disorder or obsessive compulsive disorder or something like that, or anger issues or rage, right? It could evolve into a different type of disorder. Or if that person gets treatment, it can, those physiological and psychological symptoms can lessen. All right. So psychopathology. So many of you will probably go on to take another course. A lot of times we hear the word abnormal psychology. I think that that's a word that a term that we are probably moving away from, because we don't want to marginalize people that have disorders, right? We already have the stigma associated with psychological disorders that it's a bad thing, right? It's a taboo. They're dangerous people, right? We that was one of the questions on the slide. That kind of thought really prevents people from seeking help that they need, especially when they need it. So anyway, we kind of move away. We're learning that words have implications. So if we say abnormal psychology, you know, that might be standoffish for the person to think, hey, I have depression. That's abnormal. I don't want to be abnormal. So they would look at that negatively and probably not get help when they need it. So anyway, the term that we do like to use is psychopathology, which is the scientific study of the origin, symptoms, and development of psychological disorders, as opposed to abnormal psychology. Okay, just a point on that. So there are several perspectives, as in many of the other topics that we covered, that help us understand psychological disorders. And as I mentioned earlier, we use the medical model, right? We look at a cluster of symptoms to base based on everybody else within that society, within that community. What is normal? What's abnormal? What's functional? What's dysfunctional? What's distressing? What's not distressing? Right. So based on those symptoms, we can say to a certain degree whether a person can be diagnosed. And the reason, again, we use that diagnosis is so that we can treat and oftentimes and hopefully cure that person through hospital treatment or clinical treatment method, right? All right. Oops. So one of the other perspectives is the biopsychosocial approach, which holds that the psychological disorders are the result of intersecting influences. It could be genetic, right? It could be the biological influences. It could be the structure of the brain, right? So those are all biological influences. We have psychological influences. What's going on around that person? What kind of stress are they going on undertaking? What kind of trauma did they have, right? Have they learned that they can just avoid, right? So these are all psychological influences that contribute to that psychological disorders. And then, as we kind of hinted to earlier, what are the social and cultural influences, right? What are the rules and expectations of that person, right? And we see this with athletes, for as an example, right? What are the expectations of athletes? Are they held at oftentimes a higher standard than their peers? Any
Yeah.
athletes?
Yeah, definitely.
Yeah, absolutely. Right. Not only in academic settings, but in competitive settings as well. So there are expectations that could contribute to psychological disorders. I'm very fascinated with mental health issues with athletes because, all things being equal, we have a lot of people that have psychological influences such as trauma. They have genetic and brain structure chemistry that might contribute. And then on top of it, they have these higher expectations and roles that they're expected to fulfill, which could lead to psychological disorder if untreated or undiagnosed. Okay. So how do we use this medical model to explain psychological disorders, right? So we have a book, and I don't actually have a copy with me here, called the DSM-5, Diagnostic Statistical Manual of Mental Health Disorders, 5th edition, which came out, I believe, in 2013, I believe. Anyway, this is again a publication that evolves over time. There will be a 6th one. There will probably be a 7th one. I don't know when it'll go on. Maybe they'll change the name at some point, but we're likely going to continue using the medical model because for the most part, it works, right? So the purpose of it is to describe a disorder, predict its course, and imply appropriate treatment and stimulate research into its causes, right? So once we learn more about the disorder, we do more research on it, we renorm the population, and then we make another book, basically, is what we do. So again, main tool for diagnostic is DSM-5, and this just kind of gives you an example of what diagnostic criteria would be for antisocial personality disorder. So without looking, first of all, what is antisocial personality disorder? Does anybody want to take a stab at what they think that means?
Not really wanting to go out around people or talk to people.
Okay. Oh, that's incorrect. And don't worry, Madison, you are not the only person. About 80 to 85% of people that you ask will say that exact same thing. Believe it or not, if there's one thing you can take away from psychology, introduction to psychology course, know that antisocial is not, that does not mean that it is they're avoiding, right, or they're shy or not wanting to go out and do stuff. It means opposite of social. Okay, so we think of social, people are doing like pro-social is doing things for the good of the community, right? Antisocial is opposite of that, where they're actually destructive and doing things opposite of for the community, right? So there's a pervasive pattern, as the diagnostic criteria says here. There's a pervasive pattern of disregard for and violation of the rights of others occurring since age 15 years, as indicated by 3 or more of the following, and it gives you 7 criteria that it could hit. Okay, so people that are antisocial like to see people suffer. Okay, usually I've encountered a couple clients that that were diagnosed with antisocial APD, antisocial personality disorder, and it was obvious earlier on where they would torture animals or skin animals or something like that. Sorry to be so grim and gross, but that's usually the kind of behavior that we see with antisocial personality disorder. So anyway, as you can see, we look at meeting just 3 of these criteria, you know, failure to conform to social norms with respect to law. So we'll see kids usually get in trouble with the law very earlier on. They're deceitful, usually. There are a lot of lying. There's impulsivity or a failure to plan ahead. They might be irritable and aggressive. They have a reckless disregard for safety of others and consistent irresponsibility and lack of remorse. That's kind of the big one here. They don't feel sorry for what they did because they're very much involved in just gratifying whatever it is that they want to feel good about. Okay, so that's antisocial. And again, just meeting 3 of those is pretty big. Would be enough for a diagnosis at 15 years or up. So we also like, so the individual is at least 18 years, right? So we don't want to really diagnose a 15-year-old with antisocial personality disorder. Why? What is the danger of doing that?
Their brain is not fully developed.
Right. There could be many explanations. It could be hormonal. It could be environmental, contextually, right? It could be a relationship. It could be a phase, right? Um, the danger with any kind of diagnosis for any children really is that it could carry on for the rest of their lives, you know, and that could prevent them from getting into certain schools, that could prevent them into getting into certain jobs. So there's a lot of room. As you mentioned, the brain is still developing. And with that, with the right support, that individual could probably get help so that they would be able to function normally. So that's why we're very conservative. We should be conservative when we're dispensing diagnoses for children. Sometimes it's necessary, like ADHD. In order to get medication to help children with ADHD, we need a formal diagnosis of that, and it's something that they could outgrow later on in life. Some of them do, right? A lot of them do. So anyway, for this diagnosis, it's very clear that we want to make sure that that person is at least 18 years of age. There is evidence of conduct disorder with the onset before 15. You know, that's a diagnosis we see. Conduct disorder, again, probably a temporary one. The occurrence of antisocial behavior is not exclusively during the course of schizophrenic or manic episodes, which also might explain some of those. So anyway, the correct term for somebody that is shy, does anybody have a guess? Like somebody shy or doesn't want to go out and be with people or something. It's not antisocial.
Social anxiety disorder.
It could be. It could be, you know, diagnosed if that's an ongoing thing. But somebody just says, "Hey, you know, I don't feel like going out this weekend. I'm feeling antisocial." They would probably mean to say asocial, which means not wanting to be part of society right now, right? So they just want to stay in bed for whatever reason. So anyway, yeah, if you're the type of person that likes to correct your friends when they say antisocial, say, oh, you mean you want to go out and skin cats today? No, what they probably mean is asocial. So that'll help you be a little extra smart, right? All right. So anyway, the DSM, here's a picture of the DSM, what it looks like. Many of you that are going into the fields, you will get one of these books because it helps you with diagnosing people or conditions, right? So previous version of this, the DSM-4, which I was trained on the DSM-4, it casted a wide net on what really we thought were normal experiences, what we consider to be normal experiences. It used arbitrary cutoffs to draw the line between people with and without the disorder, and there were certainly some gender biases. Right, it looked at traditional male and female relationships, right, and we know that today to have evolved to something a lot different. So we don't look at all relationships as gender, right? As I'm sorry, as typical male female relationships. So we might use words like there as partner or spouse or something like that, as opposed to I don't know, boyfriend or girlfriend or husband and wife or something like that, right? So anyway, lack of sensitivity to cultural diversity was one of the other reasons why we have evolved to DSM-5. Okay, DSM-4 discounted. You got to really appreciate that DSM-1 was created by European and United States, Western civilization, right? And there wasn't a lot of diversity back then. We had kind of our mainstream, Western civilization, capitalistic ideals. What happened when air travel became part of our regular life? We started to see more integration of other cultures, and the DSM-1 was no longer valid, right? So we saw some pretty significant changes culturally between DSM-1 and DSM-3. DSM-4 was a little bit better. It was pretty good at incorporating those cultures, but it still wasn't enough, because in its time with the DSM-4, the internet was created, or the internet was starting to be popular. So we saw this expansion of cultures through the internet, and we continue to see more integration into Western civilization, people Middle East or Asian descent, right? So dangers of diagnostic labels. Okay, I told you why we use labels. Now I'm going to tell you what the dangers are. Okay, so labels can be biased and can bias perceptions and change reality. Right. So, for example, if somebody came up to you and said they suffered from schizophrenia, how would that make you feel? I mean, what would be your immediate thought? And it's okay if it's not accepting, because a lot of people, this is what we're taught, right? We're taught that mental illness is bad, right? So what would you think if somebody came up to you and said, hi, I'm so and so and I have schizophrenia? How might you think in that moment?
Normally I would just think, what's schizophrenia?
Okay, all right. You might want to know what that is, right? For somebody that's heard about schizophrenia, they might think that's a pretty dangerous thing. And I'll explain what schizophrenia is. Probably not get to it today. We'll get to it on Thursday. But anyway, so these labels can really alter the perceptions that people might have on them. They can be arbitrary and betray the value of judgments of others. Labels can serve as self-fulfilling prophecies, right? And I do see this a lot. I see a lot of people, especially with bipolar, interestingly enough. Not a lot. I mean, on occasion, I'll see somebody that will use that label as an excuse to behave badly. I had this one young woman that I was treating. She had bipolar disorder, and she was diagnosed with bipolar disorder. And about every 2 years, she would go off of her medication, and she was very promiscuous, which meant she liked to have sex with men. and she was married and had 3 children. So it was very damaging for her relationship. But her excuse was, it's okay, I have bipolar, I'm just being manic right now. So it was almost like an enabler for her, where she could just stop her work that she was doing therapeutically and engage in dangerous and damaging behaviors, right? So that's just one example. People with for example, PTSD, I see this happen on occasion, is once they get the diagnosis for PTSD, sometimes they just want to use it for getting a prescription for marijuana, and then they never go back to treatment ever again. Whether they think that they need it or not, it's usually just because they want that label and they don't ever want to make any positive changes in their life, right? And some would argue saying, well, maybe that's because marijuana works. you know does it? If you have to rely on a chemical to keep you balanced and keep you from flying off the handle, that's probably not a good place to start, right? um, anyway, there are a lot of mixed arguments on that. I'm sure each and every one of you have your argument as well, but if it would be no different than saying, I'm most relaxed and I can converse with people when I have a glass or two of wine, right? That's the same principle. You're using some kind of catalyst, some kind of chemical to balance you out just so you don't act a fool. And the problem with that is oftentimes it's unregulated, right? So, all right. So also labels can stigmatize people with disorders and add to stereotypes, which I think we did a pretty good job at talking about. So what's the prevalence of psychological disorders? Because we said earlier that approximately 1 in 4 survey respondents reported experiencing symptoms of psychological disorder in the previous year. Okay, again, maybe a lot of people wouldn't agree that they've had a disorder, or wouldn't, or might be in denial in some way, right? I see that a lot. How many of you have encountered somebody that might be going through some kind of depression, and what did that look like, and were they in denial? Does anybody have an example that they can think of? Or maybe not just depression, maybe anger or something. Anybody want to chime in on an example? All right. Well, if you think of one, let me know, because we're going to try and incorporate a. Christian, were you going to chime in here?
Yeah. Oh, sorry. I had to log on my computer, so I had to unmute myself. And sorry.
Okay, that's all right. No problem. All right. So anyway, just to give you an idea of lifetime prevalence estimates is, 29% of respondents said that they had anxiety disorders, right? That's pretty normal. Okay. So anxiety is not necessarily in and of itself a disorder. So somebody with an anxiety disorder, which we'll talk about in the next lesson, not this one, not the intro. Somebody with an anxiety disorder has a long track record of anxiety. That prevents them from doing stuff. Okay. So, for example, I think everybody in this room, does anybody enjoy getting up in front of a crowd of people and talking?
No.
No.
No. Does anybody actually enjoy doing it?
I don't enjoy doing it, but I got used to it.
Okay. All right. And that's great, but a lot of people would say they have social anxiety to the point, or stage fright, because they can't get up in front of people. And it's a very common thing. We all have this social evaluative defense mechanism that we don't want to be judged and thought that we're foolish, and then casted out from our group. That's terrifying. That idea is terrifying for us. So that anxiety is built into us to try and protect us in some way. But it acts as an inhibitor, right? It actually counteracts what makes us successful and makes us do stuff. Believe me, I mean, getting up in front of people is not the first thing that I would really, really want to do. But I know that my job is important, and I've had several bouts of stage fright where it I passed out twice in high school giving a book report. So yeah, I mean, I'm very familiar with what it is, but I'm also familiar with what it means to get over that. And we'll talk about like exposure therapy, just getting people exposed to things that make them anxious so that they, like Lewis said, you can get a little bit more relaxed when you do it, right? So mood disorders, 21% said they had mood disorders like depression or bipolar disorder or something like that. Impulse control disorders, right? Inability to control their impulses, control their actions, 25%, like OCD or something. 15% substance abuse disorders. That number is way low, very, very low, because a lot of people, as I mentioned, are in denial, right? Or they're underreporting. I have this weird little trick that I shouldn't tell this to you, but if somebody comes to me and if I ask them what, usually if they're coming to me for substance abuse disorder, they've done something wrong. They've gotten a DUI, they've gotten in domestic dispute or domestic fight, altercation, resisting arrest, public intoxication, whatever, you name it. If they've been diagnosed with something like that, usually I ask them how much they drink on a day, and then I triple that number because I know that they're underreporting. People that are mandated to come to me by a court or a spouse or something like that usually are just trying to play favorite, and they're trying to get me to look at them in a positive light as opposed to judging them, right? That's, again, it's a self-defense mechanism. So anyway, substance abuse disorder, 15% reported out of that number, and I think that's low. And then 46%, up to 46%, claim that they had any disorder, and that could be insomnia, that could be OCD, it could be really anything, ADHD. All right, so nearly half the people. Yeah, I kind of already talked through all these slides. All right, so that's a brief little introduction on psychology, on psychological disorders. So I have another part of this lecture here that we're going to do. All right. So the first thing we're going to talk about, we're going to break this off into chunks. We're first going to talk about anxiety and mood disorders, which will take us to the end of the class today. And then tomorrow we'll talk about personality disorders, and then also schizophrenia and what those look like, right? So anxiety and mood disorders, we look at anxiety again as being common unless it takes a track that becomes all of a sudden dysfunctional, deviant, and distressing for that person. And anxiety in and of itself is distressing. So we're going to look at anxiety disorders, general anxiety disorder, panic disorder, phobias, obsessive-compulsive disorder, post-traumatic stress disorder, and then help understand what those anxiety disorders look like. Then we'll look at mood disorders, which usually encompasses major depressive disorder and bipolar disorder. Now, true or false, depression is always diagnosable.
False.
Why? Why would you say that's false?
Some people are really good at hiding it
Or overcoming it, right?
or overcoming it. Yeah.
Yeah. Hiding it, if they're hiding it, maybe, I wouldn't say because they're hiding it makes that a bad thing. It could be a positive thing. If as long as they're processing it and they're working through it in some way, either talking to a friend or doing puzzles or just kind of taking some time to reflect or whatever that might mean. Depression is very normal. It's a defense mechanism for us, and it tells us that something's wrong and that we need to figure out a way to fix that, right? And it could be, again, chemical, and we'll get into that a little bit more. But anyway, as we go through these, I just want to kind of caveat, just because somebody might have features of these does not mean that it is diagnosable. right? We all have ideas and saying, oh, that person is a narcissist. Oh, that person is an alcoholic, or they have to again meet certain diagnosable criteria in order. And a lot of that has to do with time. How much time have they been suffering from anxiety over a specific situation or person or thing or whatever, right? So again, let's do a fact or falsehood. We'll do this pretty quickly. So generalized anxiety disorder is often accompanied by depression. What do you think? True or false?
True.
Think it's true?
I'll
All
say
right.
true.
True.
I'll say false.
You'll say false. I'm sorry here. It's actually true. Okay. It oftentimes okay, sorry, got a little derailed here. So how about this one? Identical twins who have been raised separately sometimes develop the same phobias.
True.
Actually,
True.
yes. Yep, that's true. We'll talk about that in a little bit. All right. Agoraphobia often afflicts people who suffer from mood disorders. Oh, sorry, that came from false. Agoraphobia actually is a fear of having a panic attack in open places. We'll talk about that here in a little bit. In North America, today's young adults are 3 times as likely as their grandparents to report having experienced depression.
True.
Yeah, absolutely true. And a lot of that, it has nothing to do with being depressed. It has to do with them reporting it, right? We've kind of created an environment that people are free to report that having depression and seek help, as opposed to back in the day when people were just told to keep a stiff upper lip and not complain, right? And then lastly, white Americans commit suicide nearly twice as often as Black Americans do.
True.
True.
True. Okay, that's absolutely true, and we'll talk about that in as to what some of those reasons are. All right, so let's start off with anxiety disorders. What is anxiety? We all know what anxiety is, right? Anxiety is familiar to all of us, but the experience of anxiety becomes a disorder when it is maladaptive and uncontrollable, disrupting everyday moods, activities, and thought processes. Right? Again, so if somebody's their functionality is being threatened, then we can say that they might have an anxiety disorder, right? General anxiety disorder is characterized by global, persistent, chronic, excessive state of apprehension. So it might not be stage fright. It might be just even driving. It could be anything that a person just has a heightened anxiety despite what they are going through, right? It's often referred to as free-floating anxiety, was what Freud called it, because the identified source of apprehension constantly changes or cannot be specified or identified, right? Physical manifestations include like a furrowed brow. We can see somebody that has anxiety. We talked about the sympathetic nervous system being activated when a person experiences anxiety. What happens when they feel anxious? Heart rate goes up, right? Breathing becomes shallow. They might look like they're worried in some way. They might grit their teeth. They might clench their fists. Usually, I can tell when their shoulders are raised because they're just in a little bit of a state of panic, right? So usually those things tell us that somebody is anxious, and we can kind of see that. Now, anxiety and panic they're related, but they're very much different, if that makes sense. Okay, so anxiety is pretty common. Panic disorder or panic happens when somebody's sympathetic nervous system just kind of runs away, and a lot of people would report not being able to breathe, or feeling like there's a weight on their chest, or feeling like they're incapacitated, they can't move, they can't they might even express that they feel like they're having a heart attack. Okay, so minutes of long episodes of intense dread. Now, a lot of people can have a panic attack and not be diagnosed with panic disorders. But if it happens over long periods of time, during these panic attacks, a person experiences terror, like we talked about. If they experience this several times within a short period of time, we might want to consider, what's going on, and possibly diagnosing them with panic disorder so that they can get the right treatment. The disorder often involves fear of the next attack, attempts to avoid all situations that might trigger an attack, and it can lead to agoraphobia. So agoraphobia, maybe some of you have heard that. Literally translated, it is the fear of open places. So with the what it is actually, though, it has nothing to do with somebody not wanting to go outside, right? I mean, it does mean that, but the reason behind it, we now know, is because that person does not want to have a panic attack in an open space, right? Like a supermarket. They worry that somebody is going to evaluate them, or that they're going to feel trapped, and that idea is frightening. So a lot of people feel safe in their homes, which is why they don't go out, right? And it doesn't sound like it's that serious of a situation, but when somebody does not want to leave their home for any reason, we tend to see secondary things crop up. We see their relationships start to diminish. They become difficult people to talk to or work with. They may not like people visiting their homes, but their functionality is diminished because they're not able to leave their house to do stuff, right? So we might see hoarding start to occur with panic disorders, right? So phobias, characterized by persistent, irrational fear and avoidance of specific object, activity, or situation, right? So something very specific. Like, what are some phobias that some of you have? Like, what are some things that you're really afraid of?
Fear of heights.
Right. Fear of heights, right? That's a pretty normal one. That's a self-defense mechanism that people might want. What else? What are some other things that people are afraid of?
Spiders.
Spiders, right? That's another popular one. Again, that's a normal one because a lot of people, we're afraid of things that move and look differently than from us, right? We don't understand it, right? So we're almost ingrained in us to fear things that propagate, that move differently, like snakes and spiders and things like that. So those are normal things to be afraid of, right? And that doesn't, not a lot of people can really deviate from that. To this day, I won't let. I tried to have a snake crawl on me, and I didn't get it. It wasn't anything that was pleasurable to me. I didn't like the feeling of a snake wrapped around my arm. And I'm not afraid of them. I wouldn't call it a phobia. I just have a preference to not touch them, right? So fears versus phobias. We all have these fears, but when they translate into, again, look at the 3Ds: distressful, deviant, and dysfunctional, then we would see that turned into an actual phobia. If somebody avoids going somewhere because they don't like being alone, or they stay indoors because they don't like storms, right? Or they, whatever. Anytime there's a clap of lightning, they rush down to the basement, even though there's no tornado warning. That might be a phobia, right? But anyway, so just to kind of show you the comparison. So you see percentage of people surveyed, like almost 7% of people claim to have a fear of being alone, but almost 3% of them had had an actual phobia where it was debilitating for them. Animals, for example, almost 22% of people surveyed said that they had a fear of a specific animal, right? That's not uncommon, right? If you see a gnarly dog, you probably don't want to go up and pet that. That would be a fear. Again, that's designed to help us. But if you see a dog and you start running, or you just can't be around dogs, then that would probably affect somebody's functionality, right? All right, so look, I'm gonna play this video for you here.
Among the most prevalent types of psychological disorders is the intense, irrational fear that is triggered by a specific object or situation. These fears are commonly known as phobias. Psychologists distinguish between specific phobias, fear of heights, the dark, certain animals or insects, for example, and social phobias, which include the fear of being in social situations where one might be embarrassed or humiliated. But while nearly everyone suffers the occasional fear, a phobia is characteristically different.
In order for a diagnosis of a specific phobia to be given, the individual needs to experience the fear almost every time they're around the phobic object. For example, somebody with the fear of dogs needs to become almost immediately very anxious and very fearful as soon as they see a dog. And the phobia needs to lead to some kind of impairment or distress. So it's not enough just to be afraid of dogs. You know, everybody's afraid of something or another, but to make it a phobia, it needs to be something that really is very automatic, very intense, and really gets in the way.
We learned a lot about how phobias develop in recent years. We used to think that people develop phobias because they had a terrible experience. Let's say maybe they got trapped in an elevator and developed claustrophobia, or maybe they were bitten by a dog and developed phobia of dogs. Now we know that there are several influences that converge in people to develop phobias. First of all, we do inherit a tendency to be afraid of certain things more so than other things. We call these fears prepared fears. And it seems we carry in our genes this information.
Common to all anxiety disorders is excessive anxiety. Anxiety that is irrational, uncontrollable, and disruptive to one's life.
Well, anxiety is a very fascinating human emotion. It's a future-orientated emotion where you are anticipating potential threat or danger and attempting to mobilize yourself to deal effectively with it.
Of all the forms of anxiety disorders, by far the most common is what psychologists call generalized anxiety disorder.
Generalized anxiety, it can best be defined as a high level of anxiety and worry that's pretty constant during the day. Unlike a phobia where you wouldn't feel the anxiety unless you were in contact with that particular situation, the person who is generally anxious would feel that way almost the entire day. It's also characterized by what we consider a great deal of worry about sometimes normal life circumstances.
Another anxiety disorder is panic disorder, which is characterized by panic attacks. Now, what panic attacks are where the individual becomes very panicky, feels short of breath. They may feel like they're going crazy or they're going to die. Heart beats very quickly. They may get sweaty. They may feel very hot or very cold. Their thoughts will race. It's really just what it sounds like, a very kind of a panicky experience.
There's a number of different physical symptoms. A person doesn't have to experience all of those symptoms, but usually they'll experience a number of them. At the same time, after those symptoms happen, very often the person will start to generate thoughts about what is happening to them. And often those thoughts are, I'm dying, I'm having a heart attack, or something horrible is happening to me.
All right. And those are all things that that we had described. So just, have you or someone you knew ever had a panic attack? And what were some of the things that you used or they used to try and alleviate that?
So my dad has panic attacks frequently, and he had one before, and he just like thought he was having a heart attack. Really, he made us call 911, and then once they got there, he was like, haha, laughing, like, yeah, I was just having a panic attack.
Okay.
I'm fine. Like, he was like, he tries to use humor to like help him, but not really. Didn't really help until 911 got there.
Yeah, yeah. And that can be frightening for the person, especially if they don't know what's going on. It sounds like he knows that he has them, and sometimes just the act of going to the hospital can help alleviate that for that person, right? So yeah, I mean, it is very severe. So a lot of people use breathing techniques, right? They'll find a way to remove themselves from whatever it is that they're engaged in, like usually in a public space. Get to someplace private, close their eyes, use like guided meditation or guided imagery or something, and just relax and hopefully get back to feeling better, right? So hyperventilation is a contributor because it blocks our ability to get oxygen to the brain, and it also tells our brain that something is very, very wrong. So it employs other things, increased heart rates, increased blood pressure to try and compensate for that fear response. Okay. All right. So anyway, we talked about this already, any phobias that we have and how we cope with them. Okay. All right. Understanding anxiety disorders, we look at it from a learning perspective, that it's a product of conditioning. As we said there, oftentimes it comes from people having a bad experience or traumatic experience with something that had occurred, right? Usually people that are afraid of dogs have been either bitten by a dog, and it's something that's long lasting for them, right? We can look at it from a biological perspective, is sometimes people just have heightened levels of emotional anxiety, right? Or reactivity. So something kicks in a little quicker for most people, and it could seem like they're having anxiety, but indeed that's just their normal reaction to that, right? Um, okay, so that's it for as far as anxiety disorder. We're going to branch off a little bit, and we're going to talk about OCD or obsessive compulsive disorder. And
I'm
it's
sorry. Could you go back to that one slide?
Yep.
Thank you.
Yep, you're welcome. So obsessive compulsive disorder, just like the phrase says, obsessive compulsive. So it's categorized by an obsession and a compulsion. So an obsession is an unwanted repetitive thought that we just can't get rid of. And maybe some of you can relate to this. You're up at night and you have a big day or a job interview or something going on the next day. You just have that constant idea in loop. Okay. That would be kind of an obsession almost, not really categorized as an obsession because the next day it goes away once you have your interview or something like that. But for if you can imagine somebody constantly thinking about germs or constantly thinking about being robbed or fire starting or something that they just can't get it out of their head, that's what it is. So whatever it is that you've experienced like that next day that you just can't stop thinking about, amplify that by like 100, and that's what somebody with OCD experiences with obsessions. With that obsession, the only time that it seems to reduce those repetitive thoughts is when they're having when they have a compulsion, they have an action that kind of reduces it a little bit. So, for example, somebody with OCD might experience those unpleasant thoughts until they wash their hands with really, really hot water and a lot of soap. Almost, I've known people with OCD to use an entire bar of soap on one single washing that could last anywhere from 15 to 30 minutes, right? So that's the part. Now we all kind of have heard somebody say, "Oh, that's my OCD kicking in." How many of you have heard that? Just kind of, yeah, maybe they didn't have a diagnosis
Yeah.
of OCD,
Yeah.
right? Yeah,
Yep.
many of you probably have said that. I know I have, right? So again, this is just saying that just because we have features of something doesn't necessarily mean we have a diagnosis. So maybe you like things organized a certain way. That's not necessarily OCD. That's just our brain telling us that we like things organized, right? Because we do. We like things to be routine. We like things to be where we left them because that reduces our stress of having to find it later. So anyway, OCD is categorized by invasive thoughts to the point where they can't stop thinking about it until they perform a certain action to get rid of it. So that's really the difference between what we say, OCD about organizing something and somebody with actual OCD. Okay. All right. And this is a video. Oops. a video that shows a mother who struggles with that.
Her obsessions center around her baby son, Jake.
When I come to stop signs, I have to look at him while I'm stationary for fear that someone's going to come up and take him, you know, open the door. I have to start the car before I take my eyes off him. Ah! When I'm moving, I figure nobody can get to him.
Stephanie's protective maternal instincts have gone into overdrive. It's a form of OCD that sometimes afflicts new mothers.
Like it, don't like it, don't like it. Just doesn't like. Okay. Okay. To set this trap, I'm going to use a video cassette, which I shall lean against the door. Then I'm going to take this pen and line it up along the green rectangle. And I'm going to point this napkin so the edge, if you follow it with your eye, matches up with the corner of my wall.
Stephanie fears that someone might kidnap Jake, even when she's at home with the doors locked and the alarm on.
I'm not sure if somebody might have gotten in the house while I wasn't here, so I'll set a trap. I will set things up at a certain angle that if they're moved, I'll know it. It's so pathetic.
For a walk?
Stephanie knows her thoughts are irrational, but they're beyond her control. Protecting Jake from every conceivable danger makes life hard.
Okay, get your stick.
When I can't take my eyes off Jake, it's literal. I stare at him. If I glance away, even like this, it's a chance for something to happen. He has to be in front of me so that I can see him the entire time, so that if somebody walks by, I know that they aren't going to bump him, spit on him, grab him, touch him, inject him with something, whatever. Take him.
Like many people with obsessive-compulsive disorder, Stephanie also has a fear of contamination. She avoids litter or spots on the pavement in case the wheels of the buggy touch something deadly. Passers-by pose a double threat. They could kidnap Jake or contaminate him.
Just need to make sure nobody was near him. Cigarette? If I looked away, I'll have to turn my stroller around, look behind me to see if anybody was in the area, but then I worry that maybe I took my eyes off him while I was checking to see if anybody was behind us. So I'll turn back around, and then I'll turn back around the other way, and I'll just spin around in circles until I feel relatively sure that it's okay. Sometimes it's hard for me to go for a walk because I can never get home, because I'm constantly having to turn around and go the other way because there's somebody coming. If somebody's walking towards me, then I get frantic.
No, that's... please keep him on a leash.
And it's a fear of never knowing if he was contaminated. It's like I'll never know if that person who walked by touched him. And that will eat away at me.
Before Jake was born, Stephanie was diagnosed as having OCD. Her obsessional fear of contamination leads to compulsive rituals which she uses to manage her anxiety.
When I am going to interact with Jake in some way, I have to be certain my hands have been just cleaned. And they have to be scoured clean.
The urge to perform these compulsions is so strong that in this half hour, Stephanie washed her hands 22 times.
It's torturous. I wash my hands continuously. I know I try to stop myself, but it's almost like my feet begin moving for the sink, and I'm trying to tell myself not to do it, but I'm desperate and I have to.
And the washing ritual is complex and has to be performed absolutely correctly 3 times.
I have to lather up my hands completely, drawing my fingers through my other hand. The water has to be as hot as it can be. I start with my forefinger and scrape under my left thumb, and then I switch to my thumbnail and go to my forefinger, the middle finger, ring finger, and then I get to the pinky and I switch to this hand and go back and forth several times, and that just gets the first layer of contamination off, because I still feel, since I scraped under my nails, that it's somewhere on me. So I have to get another pump and do it all over again. And this is really the one that I feel cleans me, because now my nails are clean, and now I'm just going to scrub my hands. And then I have to do a finishing rinse. This is the part that's hard, because the water's really hot, burning, but sometimes I keep my hands under there just to feel better. And then I get my towel, and I will be careful not to touch the garbage when I put this in, so I have to... Oh! And
All right. So what'd you think about this case, this issue, OCD?
I feel really poorly for her, because I personally have struggles with OCD, primarily obsession OCD, and I know that it's obviously something that you can't really control, and like I said, I have primarily obsession OCD, so I don't so much have the compulsions, but I know that the physical compulsions to, be feeling like you have to do things and engage in things that you know are irrational, or that you know that you don't want to be doing. That's something that could be very difficult and stressful to deal with and to cope with.
Yeah, absolutely. And and we could probably try and guess all day, like in the case of Stephanie, what might have caused that, right? Was it maybe she was sick, and that created some kind of phobia for germs, which then spun into obsessive compulsion. We see that a lot. We see phobias turn into obsessive compulsive disorder. But very, as you can see, I mean, it's nothing to, and the implications are so great with what's going to happen to her son. Do you think what is this going to be a healthy relationship for her son growing up?
I think it can definitely turn into an unhealthy relationship between her and her son. And I think definitely as her son gets older and gains more independence, it can definitely be an area of conflict for them, where he feels that she's being overbearing and like helicopter parenting, and feels that what she's doing is unnecessary, but in her mind it's very necessary. So it can definitely be a really difficult situation.
Absolutely, yeah. And what her intentions are is to keep him safe, might spin off into him trying to separate from her, which would be problematic. That might raise her anxiety even more, right? So usually in these cases, talk therapy, usually psychotropic medications help to reduce that physical anxiety and obsessive compulsive or obsessive thoughts, right? Because if we don't have the thoughts and we don't have that obsession, then the compulsion kind of just goes away. So anyway, like I said, there are several methods to reducing that. Just from talk therapy, cognitive behavioral therapy, rational emotive behavioral therapy, just various types of therapy, and oftentimes along with medicine often helps us. Okay. So let's shift gears to PTSD, post-traumatic stress disorder, which happens. It's characterized by haunting memories, nightmares, social withdrawal, jumpy anxiety, and or insomnia that lingers for longer than 4 weeks after the traumatic experience. So it's pretty normal for somebody to experience something that might have them fear for their lives or the lives of their family, or even their well-being. And with that, usually if it's a single event or a sequence of events, normally people just start to reduce that anxiety and that fear of it happening again, and it just kind of goes away. Oftentimes, though, that's not the case, especially with death, if death is being endured or occurring, and we have a fear of death, right? We're pre-programmed to not die. We're pre-programmed to survive the best way we can. And when somebody experiences a situation that puts that fear into them, they might hold on to that fear for weeks after or years after, right? So when we see that occur, I apologize. When we see that occur, usually we try and again get them into some kind of EMDR or some kind of therapy that helps them process whatever trauma that was, so that it doesn't become so frightening that it's debilitating for them, right? So most people who experience trauma do not develop PTSD. It is diagnosed when symptoms are so severe and distressful that they interfere with daily functioning, as we talked about. We don't have a whole lot of time here to, let's see how long this video is. I'm going to skip this video for now. Actually, let's see. What else do we have? Yeah, I'll skip this video. Actually, I'll play this video because I think it's going to be good at highlighting what we talked about, and then we'll
There's nothing like being in a firefight that, you know, gets everything moving. Every emotion you ever sustain, you got that within 2 minutes of a firefight. It was a very frightening thing. You lay there, you're helpless, because you don't know where they are. They're throwing grenades at you. They're shooting machine guns at you. You don't know if you can get up, run. There's no hiding, because they'll find you. I mean, where can you go? Nam was hell. Nam took our souls, and took my soul, and took it away from me. Whatever goodness, real goodness I had, the happiness, it's still over there somewhere.
Psychiatrist Doug Bremner has been working for 10 years with patients like Dennis, who have been permanently traumatized by the terror they experienced in Vietnam.
Dennis has symptoms of post-traumatic stress disorder, including intrusive memories of the war that come back to him at any time of the day, in which he has little control over, and they replay in a repetitive manner. He has nightmares of the war. He's jumpy and easily startled. He's hypervigilant and on guard all the time.
Nearly a fifth of Vietnam vets returned, like Dennis, traumatized.
I feel trapped in my life. I feel like I'm trapped in some kind of shell, that something that's never going to go away. I'm suicidal at times, and hopelessness. You know, and the dreams. I think because of thinking about Vietnam so much, and how hopeless that situation is, I just kind of carried it into my life today. I don't like busy streets all that much. I try to stay away from it. Walking in the streets of New York or somewhere, I'm a little more watchful, you know, of the ambush.
Someone like Dennis knows that anyone could pop out of the bushes at any time with a gun and shoot you, and there's nothing that you can do about that. And he walks around with that knowledge all the time. But that makes it more difficult for him to work and to be close to his family and to do all those other things that we all take for granted.
Dennis is on a hair trigger to fear. Cars backfiring, or just the smell of diesel take him back to Vietnam.
be a perimeter set up here, quick. Oh, man. Perimeter set up around us. Get another company in there. You got a first aid kit here.
All right. So one last note on PTSD is we've come to learn really that it just doesn't affect Vietnam vets, or prior to that it was what was it called? Shell shock was the original term we saw as a product of war, and World War I and World War II. And that branched off into Vietnam because there was a lot of death involved and people feared for their lives. So we saw that trauma happen there. We saw that happen in the Gulf War. We've seen it happen in Afghanistan. So the interesting thing about PTSD is it not only affects war veterans, but it also affects people that have maybe had car accidents, right? Or maybe some kind of physical violation against them, either physical or sexual, right? That could cause PTSD as well. So again, treatment with PTSD usually involves talk therapy and a regimen of medicine as well. Okay, so I'm going to stop here for today, just because I am going to I want to talk about mood stuff and I don't have enough time today to do it. So were there any questions? What do you all think about the lecture today? Was it helpful?
Yeah, definitely.
Yep, I think so.
Okay, and hopefully the takeaway you got from today, not only what some of these disorders are, but also antisocial personality disorders is not wanting, it has nothing to do with not wanting to go out and be with people, right? All right, so that's all I have for you today. Have a great rest of your day. I'll see you all back here on Thursday. Bye-bye.
Thank you.
Bye.
Thank you.
Thank you. Have a good day.
Yep, you too.
Thank you. See you Thursday.
All right.